Good day, students. I'm going to talk about Introduction to Ocular Disease as part of the introductory course in clinical ophthalmology. I will be talking about, first of all, about the anatomy of the eye, just to revise what we've learned in the past about the different parts of the eye which contribute to vision and also visual processes. The following are the sections of the eye which we have covered before in the past. And as you can see, we can start with the anterior segment, which refers to the part of the eye that is up to the lens. We have the external eye and next, which is really the outer parts of the eye. Posterior segment, the part that starts from the lens to the retina, the vitreous and the retina, and the fundus, which is the view of the retina from the front of the eye, the optic nerve, and the visual pathway. Now, this is a picture of the external part of the eye. It's obviously an eye from a Caucasian person because of the blue iris, the color of the iris. You'll find that you can see the front of the eye, which is white in color. That's the sclera, which has a mucous membrane overlying it called the conjunctiva. The iris is part of the uvea. It contains muscles that can make the pupil, which is the opening of the eye, smaller or bigger. So in different lighting conditions, you'll find the pupil will adjust itself to different sizes to optimize the vision that you're getting. This is a cross-section of the eye, a very schematic to show the different layers that are found in the eye. And the important ones are the cornea, the sclera, the choroid, and the retina. If we talk about the anatomy of the eye proper, we'll find that textbooks will say that the cornea and the sclera are or make up the part of the eye, or the fibrous tunic of the eye. Choroid and the iris and the ciliary body make up what we call the uvea, and the retina is the nervous part of the eye, or the neural part of the eye. Now, when we look at something, images will fall, or the image will fall on the fovea, which is the little pit on the back of the eye in the retina itself. The processing of any visual images, of any visual image, starts in the retina, and information is then sent through the optic nerve to the visual pathway and finally to the brain. This is the same section of the eye, but showing the different layers more schematically. The layer which is marked as yellow is the retina, and the reason why I put this one up is to show the fovea, where when we look at something directly, the image of that something that we're looking at actually falls on the fovea. The beginning of the optic nerve, as marked here, is called the optic disc, and it gives a lot of indication about the health of the eye. The appearance of the optic disc has very good clues about the health of the eye, especially when the intraocular pressure gets high. Now, by intraocular pressure, I mean the pressure within the eyeball itself. I have not so far mentioned about the vitreous. The vitreous is actually the gel that fills up the posterior part of the eye, behind the lens. And in front of the lens, we have what we call different kind of fluid called the aqueous humor. Now, this one then sent to the brain via the optic nerve. This slide shows the microstructure of the retina, where there are about 10 layers of subretinal structures, and each layer plays a part in initial processing of any retinal image, and they also transmit images to the optic nerve after having processed the nerve primarily in retina. Now, I did also mention about the fact that everything now then goes to the brain. This is a very schematic diagram of how the optic nerve, which is marked as yellow here, goes to a structure called LGN, or lateral genicular nucleus, and thereon the visual to the back of the head, and it's called the visual cortex, where visual information processing at the highest level takes place. Now, I also need to tell you that the eyeball, or each eyeball, is moved by 6 muscles. And this is very important because we need to move our eyes to the left, to the right, up, and we also need to, what we call, converge the eyes when we're looking at something at near. So the 6 extra ocular muscles, as they are called, 4 of them are called the rectal muscles, and 2 of them the oblique muscles. We've done this before, so there's not much point in going through the actions of each muscle. Right, now let's come back to the original topic of the lecture today, and that is to talk about the diseases or problems that can occur in the eye. Now, I have brought up this question of what are the most frequent and serious problems. So we don't want to go into all the problems that can happen in the eye, because that would be a whole day, I suppose. But if we look at just the main ones, and we look at the symptoms and the signs, you'll find that most people would have a decrease in VA, or visual acuity, or vision in layman's terms, although there's a difference, because of the presence of an optical defect, or what is called refractive error, or ametropia in its scientific term. It has been shown 1/3 of the population wears some form of optical prescription for the correction of myopia, hyperopia, astigmatism, and presbyopia. These are optical defects, and optical prescription takes the form of spectacles or contact lenses. In as far as blinding conditions are concerned, in the Western population, you find that in older people, in the older population, defined as more than 65 years, a disease called age-related macular degeneration seems to be the most common cause of legal blindness. What about in Malaysia? Vision statistics are slightly different. We find that a landmark study carried out in 1996 by a group of ophthalmologists found that cataract as the leading cause of blindness, followed by conditions of the retina. Cataract is a condition of disease of the lens, and we saw that in the anatomy tiger just now. And what was surprising as well, in their findings, was that they found uncorrected refractive errors to be a major cause of low vision as well. So it's true when we say that people are not being corrected properly for the optical defect that they have. Hence, that's what optometrists are here for, to detect and to correct optical defects that are causing visual impairment. Although that study was the landmark study, but anyhow, it has become a bit outdated now. So I think there's room for a new study now that this is the year 2011, and a colleague who has passed away now, Dr. Selvaraja, actually made a suggestion that there should be a later study after the National Eye Survey. Having looked at the most common problems that can cause blindness, let's have a look at some other problems which are frequent, but they may not be necessarily blinding. So I have listed them out into these sections. So if I may just go through them very quickly. First is trauma, or any accident to the eye. Second is acute conjunctivitis, inflammation of the conjunctiva, which is the external membrane of the eye. Any infections of the nexa, or the sinuses, the openings in the skull, close to the eyeball. Strabismus, or what is known as squint. Cataract, we're going to go and revisit that again. Glaucoma, and complications that arise from hypertension and diabetes. And lastly, but not least, we're going to have a look at some tumors that affect the eye. Let's have a look at the first one, trauma. Well, I mean, rarely, I don't think optometrists will ever see this condition, but this is, kind of trauma, which is so traumatic. You have a knife that is sticking into the eye, but trauma is traumatic, as the name implies. It's very common in Malaysia, auto vehicle accidents, and if the cornea is affected, then it's going to cause disability, apart from pain. And when the cornea heals, if it ever heals, vision is going to be affected because of the scar tissue. So trauma that affects the cornea is bad news. Right, acute conjunctivitis, every now and then you get a red eye, and this is a schematic diagram. This is a real diagram of conjunctivitis. The eye is red, there is discharge from the eye, you wake up in the morning and you can't open your eyelids. It's just infection from either bacteria or virus, and virus being the more common one. This is also another picture of conjunctivitis. The eye is generally red, but vision is not affected because the cornea is clear. So it's sometimes referred to as the pink eye. It is an inflammation by nature. Pathologically it is inflammation, and it can be caused by other things besides bacteria and virus, chiefly allergy, and also any form of trauma can also inflame the conjunctiva. Or if you have an infection in the adjacent sinuses, that can also give rise to a conjunctivitis. Next, strabismus or squint. Now, sometimes a child comes in and the eyes are not quite straight, so one is looking in or looking out, so that's called strabismus. This particular one is called an esotropia because the eye is turning in, and it's a left esotropia because the left eye is turning in. You can also have exotropia or divergent squint, as the picture on the left shows. Or you can have something that affects the vertical direction of the eyeball, and they're called vertical squint or hypertropia. It can either be left or right. And the diagram on the right is a convergent squint or esotropia. Now, it is a common condition. We haven't got real statistics in the Malaysian hospitals, the Malaysian population, what the prevalence is, but it has been said that exo conditions are more common than eso conditions. Anyway, we need good data on that. What causes strabismus? It's a problem with the nerve supply to the eye, or it's either a problem with the nerve supply or the muscles are somewhat affected by restriction or by something that's growing on it. Next, cataract. Here we are, a boy with cataract in his eye, and it's so mature in this case that you can see the eye as being white. So, sometimes people refer to as cat's eye. This is a blown up photograph of a cataract. It looks really milky here, and by no stretch of imagination, here you can say that light can pass through the opaque material there. So people are going to end up with poor vision, or in this case, no vision at all, apart from just second light. So cataract is really an opacity in the lens, or of the lens. It's something that's growing in the lens. It's not a tumor, but it's just changes in the biochemistry of lens proteins. It causes a reduction in vision, definitely, and it causes what it causes. You can be born with it. It's a birth defect. It can be because of inflammation, trauma. Old age is the most common cause of it, and we've not listed here the effects of ultraviolet radiation. Next, glaucoma. Often heard, but not a lot of people know about this. If we look at the front part of the eye, let me just go through this little bit of anatomy again. You'll find that the aqueous humor actually leaves the eye through a structure called anterior angle. It's part of the physiology of fluid in the eye. somehow, if that angle is clogged, then fluid is not able to go out, so pressure builds up in the eye. So that, in very simplistic terms, gives rise to glaucoma. Alternatively, fluid can't go in, not because the angle is clogged, but because the angle has become narrowed. This is a second type of glaucoma called closed angle glaucoma. So we've got two types of glaucoma, generally. And people with glaucoma, visual field defects, they're not able to see some parts of the visual field. And this is an example of a plot from an examination with the technique called visual fields examination. And it shows visual field defect. We'll come to this later on in a clinical lecture. So, glaucoma is often said to be the thief of sight because, the patient who suffers from it doesn't know that he has glaucoma until it's too late. So the characteristics of glaucoma are there is an increase in intraocular pressure, IOP, and the increase in intraocular pressure finally damages the optic nerve. As we saw in the diagram previously, the optic nerve is actually the main nerve that carries information to the visual cortex. Next, we've got conditions that affect the retina, and I'm just going to talk about conditions as a result of hypertension and diabetes. I'm not going to talk about other retinal conditions because there are too many. So HD for hypertension, DM for diabetic retina. If you've got hypertension or high blood pressure, things are going to happen in the eye, and that will give rise to certain characteristic signs, and some of them are shown here. You've got hemorrhages in the eye, in the retina. You've got the formation of arterioles or lipid vessels being expressed out of blood vessels. You've got cottonwool spots or areas of infarction in the nerve fiber layer, and you have papilledema, which is swelling of the optic nerve head. If you have diabetes, if you have been having diabetes for the last 10 years, you can't escape from a condition called diabetic retinopathy. And hence the reason why we tell diabetics to have their eyes examined after these for a certain number of years, because if someone has diabetic retinopathy, these changes are bound to happen in the eye, and if slightly unlucky, they'll have a bad hemorrhage, and that will actually give rise to further damage in the retina. So I've got the diabetes and also hypertension, and the main pathology in diabetes and hypertension is what we call microangiopathy, or damage to small blood vessels in the retina. Right, last but not least, we're going to look at some tumors. They're not awfully common, but you can see gory pictures of cancers of the eye. There are pictures of them in textbooks, but really ocular tumors are rare. And the most important point that I want to put across here is in the child population, retinoblastoma or cancer of the retina is the most common primary ocular tumor in the child population. So here we are, on the top left, retinoblastoma. On the bottom right is the tumor that happens in adults. It's called melanoma, and it affects the choroid. Unfortunately, giving cancers is to get the eye out. So it's unfortunate that you have here someone by the name of Naizato. Life goes on. Without the eye, she's going to need artificial eye. So all is not lost. Right. Having gone through the common problems that the eye can have and experience, let's look at signs and symptoms. Let me define symptom as what is reported by the patient. So if I can't see clearly, then I would say my vision is blurred, so that's a symptom. Whereas a sign is something which the doctor realizes, notices on the patient. So if I see your eye has red, then that's a sign to me. Right, what is the most common symptom in eye care? Of course, it's not being able to see clearly, so decrease in visual acuity. It can also be a sign if someone says you can't see, but it's really a symptom because it can be a sign when I, as the examiner, find that you can't see something very well. But if you are complaining it to me, then it is a symptom. So what can cause reduction in vision? Anything that affects the front of the eye to the back of the eye, plus the optical defect or ametropia. I've got it listed down here as ametropia, corneal lesions and damage to the corneal cataracts, retinopathy, damage to the retina, age-related macular degeneration, the most common ocular condition in the Western population, any toxic or metabolic insults as a result of a systemic condition can also damage the optic nerve fibers. And you expect, not just if such was the case, you would expect field loss to be present as well on top of loss of vision. There must be a difference between blurring of vision and loss of vision, because optometrists will normally be dealing with people with blurring of vision. Some people come in and say they can't see very well. They say check the blur, as you can see on the slide here. But if someone were to complain of sudden loss of vision, this little cartoon strip shows you, then suddenly everything becomes dark. So it could have been the lights. But then, if that was the problem, then it is something that is not to be taken lightly. The sudden loss of vision, even though it comes back, can mean a lot of things which are not fun. Secondly, people can have field loss, so they may not be able to see on the side, and they can see in the front. So it can be local or peripheral. It can be just a blur or absolute loss. I can try and simulate this by showing you some of the slides. On the top left, you have someone in the middle, so it's a central field loss. On the bottom right is someone who can see in the middle but can't see in the periphery, so it's a peripheral field loss. Now, field loss can be traced back. The cause of it, the cause of field losses can be traced back to our neat little diagram on the eye and the visual pathway. And in physiology, the teacher will always make sure that the student knows whenever there is a lesion or a damage in some parts of the visual pathway, the defect will be characteristics as is shown on the right hand side. I'm not going to go through this diagram because I believe it's covered very well in physiology. Now, what are the symptoms that we normally get from our patients? Photophobia, or extreme sensitivity to light levels. So they have to wear dark glasses all the time. It's not something that is totally dangerous, but it may be caused by inflammation inside or outside of the eye if there's nothing else that's causing it. So photophobia has to be investigated carefully. Double vision. Someone might complain about not, seeing things double. So that can be due to strabismus, binocular vision dysfunction, or non-strabismic ones. Not quite squint, but precursor to squint, if you like, latent squint. And it can be pathological or non-pathological. If it's pathological, it may be due to some form of tumor that's acting on the nerves or the muscles. If it's non-pathological, it's just a binocular vision problem which can be solved through vision therapy or proper prescription of glasses and prisms. There you go. I've got simulations of what double vision means. It can be on the side or vertically, so you get therapy upset if you get such a symptom. Next is pain. Pain in the eye. It can be a manifestation of trauma, infection, or an acute increase in the intraocular pressure. As if it happens in ankylosing glaucoma. So there we are, we have different levels of pain. When someone complains about pain, it's very difficult to actually experience it yourself because it can be painful to them and not painful to you. So it's a very subjective symptom, pain. Signs. As the optometrist here, I need to know abnormal signs that may be present in my patients, and I am conveniently dividing signs into external and internal. As far as the external signs are concerned, we have redness of the eye, ptosis, which is eyelids coming down, crusting, things that are found on the lids, exophthalmos, eyeballs bulging out, chemosis, swelling of the conjunctiva, discharge, anything that's in the eye that's that's part of the watering of the eye, nystagmus, movement of the eye, involuntarily. I haven't shown you any nystagmus diagrams so far, but that's okay. And internally, there are signs on the fundus and the optic nerve head, which I can detect using different instruments. I can show you some of the photographs. And this is what we call crusting on the eyelids. It's called blepharitis in medical terms. It happens as part of the seborrhea. You get dandruff you get on your head. So it can be very irritating. You've got to clean it. This is a red eye. It's a sign again. This is also a sign somebody has ptosis, the eyelid has come down totally because of either muscle problem or nerve insult. This is what we call exophthalmos, the whole eyeball. Two eyeballs are almost bulging out. It's a problem with the thyroid gland. This is just a feat by somebody who can simulate exophthalmos. He's not really abnormal, he's just special. That's it. Or in the back of the eye, when I use an instrument called the ophthalmoscope or a fundoscope, I can see the optic disc, the fovea, and the blood vessels. So in a diseased eye, this is what you see. Things happen, changes, whitish, blood, blackish. These are not common, are not normal things. Signs. So these are, of course, they are happening. And in as far as the eye is concerned, again, if I may just reiterate, we've got signs, symptoms, and the practitioner or the optometrist can actually make tentative diagnosis of what the patient is complaining about by taking a good case history and by doing the examination, and then come up with a solution to solve the problem, be it optically or a referral to a medical